So if you're not aware of any technique, and if you go that okay, I will manage with one technique, that is I think very enthusiastic and adventurous. You should know all the techniques beforehand and read the MRIs, get the tear pattern, have a configuration of repair that you want to do. So those things are important. So you should know these techniques, and I'll be more concentrating on the all inside repair technique. And without much of theory, I'll straight go what is all inside and the things you need to know about the all inside repair and how to do it. So nowadays all the companies comes with their own all inside meniscus repair implant system, and they have named different. What you should know is how to use those implants. Each company has their own different maneuver, different pushing or firing the things. So you should know all these things and what is available in the market, and what are the advantage and disadvantage of these repair systems. Like nowadays the latest advancement is the all suture material that gives good anchorage to the meniscus. That is the newest addition to the all inside repair system. So today we are going to demonstrate about the how to use all inside using the meniscus all inside that you are going to demonstrate on a try model and also in cadavers. The tiers which are available for all inside, like very nicely demonstrated by the Professor Kamran sir and Dr. Pratik sir, the danger area you need to avoid. There is a one clear or a very ideal indication to do a all inside repair, especially the posterolateral aspect of the lateral meniscus or posterior 1/3 of the lateral meniscus, where there are neurovascular structures that are there. You don't want to pierce, I don't want to injure those structures. That is the ideal place where you can use. The rest of the things can be managed with all inside out or outside in. But another advantage of all inside repair is the time, but it is at the cost. It is at the cost of money. And these are the instruments, like you need a probe, then you need a diamond rasp to clear and get a very good vascularity at the tear ends. And you need the cannula where you glide the all inside meniscus to avoid the injury to the cartilage. And you need a cutter and any meniscus of your choice that you can use depending upon your comfort, cost and your practice. The principle behind all inside is it anchor their implant that are dislodged when you fire. It may be a peak anchor or a all suture anchor that gets dislodged when you fire, and it gets anchored on the capsular side of the meniscus. And when you tighten it, it is like adjustable loop kind of thing. When you tighten it, the tear ends they get approximated to each other. So thing is another basic principle of meniscus is the repair. Whatever you do, whether it is inside out or all inside, it should be the perpendicular to the tear. That's where you get a good approximation. And as Pratik sir has highlighted about the vertical matters and horizontal matters that you can do in all inside also, depending upon where you are putting and how you are putting how you are piercing across the tear. This is a demonstration for the horizontal mattress that you can use, and we'll go with the video. As you know that you need to identify the tear pattern. Here is the longitudinal tear at the posterolateral part of the meniscus. The first part is to get the tear ends debrided, so that you will remove all the sclerotic or rounded or non-healing part of the meniscus. That is very important using a diamond rasp. And once you have a good roughening of the tissue there, then you can the next step is to measure the width of the meniscus. That is also important, because you don't want to pierce too far into the capsule to avoid any injury to the structures. You can use with a probe also, and most of the time the company recommends around 16 to 20 mm, but better measure and do the things. The one suture you pass across the tear and get another one is the near, just like a fracture, as sir was telling, far cortex and a near cortex kind of thing. And this is a typical of vertical mattress that you can do, and you can tighten. The tightening is very important. If you over tighten it, you may get the pull out of the implant sometimes, or if the tissue is very friable or not healthy, and sometimes it get crumpled. The tissue get crumpled, especially when you are putting a horizontal stitches. And later you need to check for the approximation of the tear, and that's how the vertical matrix has been put using a all inside. Then next is you can use in bucket handle, the extensive bucket handle tear also. Most of the tear are taken care using inside out thing, but in the posterior part where you need to do avoid the neuroscleral injury, there you can use all inside technique. Here I put just posterior to the body. The another thing you should know is when you are doing here you can see that it is unstable in the posterior part, and I try to attempt the posterior part using a horizontal matrix. And you see that one of the disadvantage of putting horizontal matrix in all inside or inside out is there's a one bite has gone, the second bite in other thing. You see that the lifting of meniscus or dog ear that has created. One of the disadvantages, if you over tighten it in a horizontal matrix, you can get this kind of lifting of the meniscus. So best is to put underneath of the meniscus whatever the pattern you need to, so that you can anchor to the tibial, meniscotibial capsule or meniscotibial. The reduction is very good. The other I put in the underneath of the meniscus in a vertical fashion that has taken the meniscus to sit very nicely on the tibia. So you can use whatever pattern you want depending upon the tear. Most important is to get the tear pattern, and don't assume that all inside is only done with the implants. This actually all inside is a concept where all the suture mats are done within the joints. That's why the name is all inside. But you can do all inside without implants also. You need this particular instruments which is antegrade self suture retrieval system. Some of the tears that can use using this instrument is the radial tear, oblique tear, or horizontal tear. This is one example of such repairs that using a self retrieval system. Yeah, this is an oblique tear. Many people used to indication for meniscectomy before, but here you can see that one suture has been put on the far meniscus tissue. The second suture is put. This is the advantage of this system in oblique tear. Other thing is you can directly get the perpendicular to the fracture, perpendicular to the tear that you got. That is very important. If you are not perpendicular to the tear, then there is no good approximation. So the periphery part of the oblique tear, I repaired it using two sutures that have retrieved through the joint using a self-retrieval knee system. Just like a shoulder that you get a bite for the rotator cuff, no? The same but with a smaller instruments. So that is a one bite, and other bite has taken and it is like making a virtual cannula. Importance has been explained by Dr. Pratik sir. And another bite, another suture has been put to make it more stable and a good environment for the healing. And the rest, the sclerotic and very part has been debrided on the central part of the meniscus. And you can put the sutures using a knot pusher. So there is also kind of all inside meniscus repair. So don't assume that all inside meniscus is not necessarily the implants. There is another tear, radial tear. There is a posterior tear of the lateral meniscus. This attempt of healing was there, but still the tear is visible. Again, the first step is to debride and get vascularity across the tear and get a good bite on either side of the tear, and using a knot pusher do a very good approximation of the tissue to get a repair. So this is also kind of all inside repair. So take home message, one should understand the pattern of tear before you are planning what kind of repair you want to do, what kind of technique you want to use, and one should master all the techniques before handling any meniscus tear in your practice. And you should know the understanding of these implants, how to use, how the fire has been, how to fire it, and how it dislodges. All this you need to aware these things. Without awareing or getting understanding of these instruments, then you end up having some complications if you are not well aware. So you have to reduce, debride the edges, then plan the configuration depending upon the tier and the instruments and implants you have, and that's suitable for that particular tier. Thank you.
Thank you, Dr. Vijay. Any questions for him?
Sir, if there is a need to, let's say, put in 2-3 sutures via fast fix, it becomes more costlier than ACL.
Yes. Definitely. Definitely. That's the reason I told it is at the cost
not
of
covered
money.
in any schemes.
Sorry?
Not covered in any AIIMS or other schemes.
That's the reason you need to aware of all the other techniques. Not necessarily you should go with one single bias that I need to do only all inside because I know only all inside. Don't do that one. You should know other techniques as well.
See, in my introduction, I told that one of the reasons for not doing meniscus repair is cost. So, you can reduce the cost by changing your technique, by not using the all-inside implant. You can use simple sutures which are available and simple needles which are routinely available in the OT. Patient doesn't have to pay anything for it. So, if you have the intent to repair, you can do it with a low cost also.
And all the tier, not necessarily you need all inside. So it is a particular where you think that neurovascular bundle you are violating and you need to put prevent all those things, especially the posterolateral corner area. That is where one or two you can use. Not other body and other things you can well manage with outside in and inside out.
I'll tell you the real situation which happened with me. It was between the 2 waves of COVID when the hospital was open for say about 2 months. There was a patient, a lady with a bucket handle tear of medial meniscus. We advised her surgery. She went to the social worker for estimate, and it was around 1 lakh rupees because of the all-inside implant. He came back to me, he has lost his job and he doesn't have money. So I told him I can do it in 2,000 rupees, where he has to just pay for the disposal for the arthroscopy, but at the cost of an extra incision on the medial side of the knee. I did a all inside out repair for her in 2,500 rupees, which he could afford instead of 1 lakh rupees. So if you have the intent, you can do anything.
Vijay, is there any implants, specific company specific implant which you find easier to use and more reliable? Sometimes what happens, they pull out into the joint and this is not how
So, two things.
faculty and do you find that one specific all inside implant is better?
So all are equally good. Only thing comes with the complexity of using it. Depending upon complexity of using it, you find one superior or other. But for the repair system, dislodgement, and these all are equally happening in all the companies. The complexity varies with one company to other company. I used all the 5 things. So processor is again need practice, sir. If you practice, any company would say that it is good. Some people they say the Athex is good, some people they say the Striker is good, some people they say Syrinx is good. 2 things you should remember is the dislodgement of the implant. It should not fire unnecessarily, and there should be a stop gap arrangement or ensurement of dislodging the second implant. Whatever the company that ensures that second implant, you need to aware that getting a click sound, many will be using that will getting a click sound or a feeling. So both the things, any company that has a feeling and a click sound that ensures that second implant is not dislodged, you go to that company.
Your question was backing out of the implant.
No, which company is good for the
which is most not exactly ergonomic, but easiest to use with respect to complexity. because we have to fire two implants. Sometimes it gets stuck, sometimes it pulls out.
So one problem is firing early, but I find my hand is not firing.
Exactly.
So you fired the first one, that goes with easy. Now what
Second is
happens?
the
The second one has
second
to
is the
then
issue.
be charged. So how it arranges it? It's arranged in a fashion that when you doing the first part, your first widget, that implant, is well positioned. Now once you fired it, whenever the firing instrument, that hook comes back, the second one has to get in position. Now that's where the biggest problem is. Now with the better implants, we are having lesser problem. We have lesser problem of premature firing. We have more problem of not firing the second one. Now you're fully stuck. One thing is inside, the other thing is you don't know where. And you got a big hole through which you have put the first one. And the one thing is lying, your implant is lying on the other side, and the other one is in your hand. So that's where there's a bigger problem. So if you can ensure, so most companies have been working on this, so there is no misfire second time when you are there. That is a company you want to go for.
So all the now company coming with second and third generation. So they have whatever sir has mentioned. This has happened with the first generation a lot. Nowadays the incidence has decreased. I think like if you're using a fast fix the first generation, the after X1 meniscus cinch, there were two needles going through, and you are getting stuck. Very complexity. Now everything has been reduced, but still there is a room for misfiring or premature firing or firing at when you don't want actually.
Thank you, Dr. Vijay. May I invite Dr. Vikram?